Hello, aspiring RNs. Welcome to our NCLEX-RN review. I'm your guide to conquering the next generation NCLEX. And today we'll go deep into the essentials, break down an unfolding case study, master clinical judgment, and nail down those NGN style questions.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere, at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Let's get started. So the first test type that we are going to work on is hotspot or highlight test type. And the case scenario says a 2-year-old male presents to the emergency department accompanied by his parents. The child appears pale and thin with a distended abdomen, is increasingly irritable and uncooperative, and is below the 5th percentile for weight. And we have the following information for the medical history. The patient is breastfed until 12 months, transitioned to cow's milk and solids, barley and rye introduced 4 weeks ago. Past medical history stated no prior hospitalizations, no diagnosed chronic conditions, occasional mild upper respiratory infections, resolved without complications. Present medical history says 3-day history of worsening watery diarrhea, 6 to 7 stools daily, large, pale, oily, frothy, foul-smelling stools since introducing barley, rye 4 weeks ago. Reduced oral intake, irritability, weight below 5th percentile, no known allergies, up to date with a DTaP 4 doses. We have IPV 3 doses, MMR 1 dose, varicella 1 dose, Haemophilus influenza type B 4 doses, and PCV 13 4 doses, hepatitis A or B 3 doses, hepatitis A 1 dose, annual influenza last dose 3 months ago. And the family history says maternal aunt with celiac disease, no other autoimmune conditions reported. So your task is to highlight those assessment findings and lab results that need urgent attention. So here's the emergency department nurse's progress notes. At 1400 hours, child lethargic, apathetic, uncooperative during exam, abdomen markedly distended, soft with hyperactive bowel sounds. Mother reports 6 to 7 large, pale, frothy, foul-smelling stools daily, now watery today. Skin is pale, dry, muscle wasting noted in legs and buttocks. Weight of 9.2 kilograms, vital signs, temperature 36.7 degrees Celsius, pulse rate of 122 beats per minute, respirations 32 per minute, and blood pressure of 88/52. IV access established, blood and stool samples sent for analysis. At 15:30, child refuses juices and crackers, grimaces during abdominal palpation, 3 additional watery stools since arrival, IV fluid started at maintenance rate, and dietitian and gastroenterology consults requested. And here are the following lab results. For hemoglobin, it's 9.8. serum albumin 2.4 grams per deciliter, potassium of 3.0 milliequivalents per liter, sodium of 128 milliequivalents per liter, chloride of 90, stool fat content markedly elevated. We got stool culture that's positive for Clostridium difficile, and pending result for the tissue transglutaminase IgA, and total IgA is 50 milligrams per deciliter. So I want you to pay attention into those results and assessment data that would require an urgent attention. So let's go ahead with the progress notes. So what do you think are those phrases that you should highlight? So the first one that you should do is this one right here. It says child lethargic, apathetic, and cooperative during exam, because these behavioral changes are abnormal for a 2-year-old, and this suggests acute neurologic deterioration. And this is something that you might see due to electrolyte disturbances, taking note about the sodium that is 128, or the dehydration caused by the ongoing diarrhea. And so this is going to happen when the brain is affected by fluid or electrolyte imbalances, and that's why this child is lethargic and withdrawn. And these are early indicators of potential central nervous system compromise, and this must be addressed promptly to prevent progression to seizures, altered consciousness, or even coma. Now, the next phrase that you should highlight here is mother reports 6 to 7 large, pale, there's frothy, foul-smelling stools daily, now watery today. So the high frequency and the nature of these stools indicate malabsorption and severe fluid loss. And the appearance of the pale, frothy stools are actually consistent with steatorrhea, which suggests fat malabsorption, and this is linked to gluten sensitivity or the infection. And the watery consistency signals acute diarrhea, which can quickly lead to dehydration and hypovolemia in this toddler. And since children have a less fluid reserve than adults, and such losses can compromise their circulation, their organ perfusion, so we definitely need to resuscitate the fluid volume for this client, and this is an urgent priority. Now, what else do we have to highlight here? The next one is 3 additional watery stools since arrival, because this finding confirms that fluid loss is ongoing and worsening even in the emergency setting. And each episode of diarrhea compounds the fluid deficit. This is going to put this child at immediate risk for circulatory collapse. And the continuation of diarrhea after arrival to the emergency department also suggests the underlying condition. There is infection coupled with a malabsorption, which is actually active. And so we definitely need to aggressively treat this pediatric patient. Now, what else are we going to highlight, especially with the lab results? One of those is the serum albumin of 2.4 grams per deciliter. We know that this is a protein that is supposed to help maintain oncotic pressure, which will keep the fluid inside the blood vessels. And with a low albumin level, especially in the context of diarrhea and malnutrition, this simply means the body is losing protein either through the stool or from impaired synthesis due to inadequate nutrition. And this will contribute to third spacing. We're talking about leakage of fluid into the tissues, which can cause edema, and this will also reduce circulating blood volume. And so we definitely need to address both fluid and nutritional needs for this client to restore vascular stability and also to prevent complications such as hypotension and tissue hypoxia. Now, what else do we need to highlight? We have potassium of 3.0 milliequivalents per liter. This is critical. And we know that potassium plays a critical role in maintaining normal cardiac and muscular function. And this hypokalemia is caused by the ongoing diarrhea, which can place the child at risk for life-threatening cardiac arrhythmias. So we definitely need to correct the hypokalemia here. Now, what else? We got a sodium level of 128 milliequivalents per liter. This is hyponatremia. We know that sodium is very important for neurologic function and fluid balance. And this, especially in young children, a rapid or maybe profound sodium loss can lead to brain swelling. It can lead to seizures and even decreased level of consciousness. So this is something that you need to act upon very quickly. Now, what else do we have here? We have a chloride level of 90 milliequivalents per liter. So this is supposed to help regulate the acid-base balance in the body. But here we are actually losing, or the child is losing, way too much of the chloride, especially when there is sodium loss. And when this client has hypochloremia, this can contribute to metabolic alkalosis, especially in the presence of other electrolyte imbalances. Although it's not immediately life-threatening alone, but if this is further disrupted, this can impair the circulatory function. And we definitely need to replace the chloride here to ensure effectiveness of the other treatments. Now, what else do we have? There is that stool fat content that is markedly elevated. This confirms that there is steatorrhea, which may be related to the acute damage to the intestinal mucosa or an early presentation of celiac disease following a gluten introduction. And so this results in loss of both nutrients and water. This can worsen the child's nutritional and hydration status. And we also have the stool culture that is positive for C. diff. This is also a critical finding here. This indicates an active bacterial infection that causes colitis and profuse watery diarrhea. And this infection can spread easily. This can worsen the fluid loss rapidly. So this client needs to be on contact precaution. And this is required immediately to prevent the transmission along with other treatments. Now, what else do we have here? I think we've pretty much covered all those findings. So let's go into the other assessment findings that are not considered urgent. So one of those is abdomen markedly distended, soft, with hyperactive bowel sound. So this is consistent with the hyperactive gastrointestinal activity, which is seen in a malabsorption and an infection. But these findings do not directly threaten the child's airway, breathing, and circulation or neurologic function. And they're also important diagnostic clues, but not the immediate focus when fluid losses and altered mental status are present. Now, what else do we have to identify as non-urgent? There's that skin pale, dry, and this is something that you would associate with dehydration, but it's considered as secondary manifestation. And the priority is correcting the underlying cause, the ongoing diarrhea, and the fluid losses. And once the circulation is stabilized through IV fluids, the skin signs typically will improve. What else do we have to consider as non-urgent? There's that muscle wasting noted in legs and buttocks. These are signs of protein energy malnutrition, which may be acute or chronic. However, it does not represent a current life-threatening emergency. So the more pressing concern here is fluid loss, not body composition, which can be managed later with nutritional rehabilitation. Now, what else do we have? We have weight of 9.2 kilograms. That's actually the current weight the patient have. It reflects spore growth and recent weight loss, potentially due to the chronic malabsorption or acute dehydration. Even though this is significant, this is not an urgent clinical concern in the emergency setting compared to the issues that we have already identified. What about the vital signs here? We have temperature 36.7, pulse rate of 122, respirations 32, blood pressure 88/52. So the child's heart rate and the respirations and the blood pressure suggest early dehydration, but are within the acceptable ranges for this 2-year-old. And these findings confirm volume depletion, but are not as urgent as active fluid losses that continue to drive further instability. Now, what else we have? We have the child refuses juice and crackers. So the food refusal is common in children who are ill or uncomfortable. And while this may contribute to the nutritional deficits over time, this does not pose an immediate threat and is less critical than correcting the child's fluid and electrolyte balance. This one right here, grimaces during abdominal palpation. So these facial expressions of discomfort are nonspecific, and this may indicate abdominal pain or tenderness. However, this is not a life-threatening symptom, and this can be assessed more thoroughly after the child is stabilized. Now, looking into the labs, we have a hemoglobin of 9.8 grams per deciliter. This indicates mild anemia, may occur with the recent gastrointestinal losses or malabsorption. However, this level is not low enough to affect oxygen delivery to tissues, and it does not require immediate intervention like blood transfusion. So it is not prioritized in this emergency context. Now we have the tissue transglutaminase IgA, which is pending this time. And so this is a test that is considered as a marker for celiac disease. And while the result will be important for long-term management, it does not affect immediate treatment. And total IgA, 50 milligrams per deciliter, is normal. And this is not clinically urgent as well. This is a routine part of the workup and not a priority during the acute care. So I hope that you were able to capture all those findings and lab results. Let's move on to our next test item. So here we go. We have a bow tie, and the nurse's notes are nothing new here. We still have the same lab results from hemoglobin to total IgA. So your task here is to fill in the diagram by choosing from the options provided to identify the problem the patient may be experiencing, 2 contributing factors or risks, and 2 potential complications. Now let's look into the different options for the problem. One is malabsorption crisis. There's acute viral gastroenteritis, inflammatory bowel disease exacerbation, diabetic ketoacidosis, and lastly, cystic fibrosis crisis. The answer here is malabsorption crisis. Although the child recently began consuming gluten-containing foods, the rapid onset of those symptoms like profuse watery diarrhea, the steatorrhea, the frothy, foul-smelling stools, and electrolyte abnormalities point to an acute malabsorption. And the low serum albumin level that we have seen earlier, so that's 2.4 grams per deciliter, right? There's also the anemia. These are signs of nutritional deficiency. There's muscle wasting, there's low weight, and these suggest either a pre-existing underlying vulnerability, possibly an undiagnosed gastrointestinal condition or previous poor intake, or a severe acute enteropathy now being exacerbated by the Clostridium difficile infection. And the markedly elevated stool fat. So this one right here, this confirms impaired nutrient absorption. And although tissue grants glutaminase IJ is still pending this time, and gluten introduction was recent, the pattern suggests acute villus injury, potentially from the infection, dietary intolerance, or possibly both. And the gluten may have been a precipitating factor, but the full picture includes acute enteric infection and systemic effects. And so the other options here, such as the acute viral gastroenteritis, which is actually incorrect in this case, this is considered self-limiting type of condition, and the diarrhea is self-limiting here. It's not a severe type of malabsorption, and it would also not typically result in hypoalbuminemia or muscle wasting within such a short time frame. Now, the next option that's incorrect is the inflammatory bowel disease exacerbation, because the IBD presents differently. It will present with bloody stools. There's going to be fever, abdominal pain, not primarily steatorrhea or fatty stools. Now, the diabetic ketoacidosis, which is also incorrect. Of course, the child's clinical picture does not include hyperglycemia. There's no ketosis or acidosis. We're going to remove that one. And so this diagnosis is unrelated to the symptoms being presented here. And lastly, cystic fibrosis crisis. This is something that can cause steatorrhea due to pancreatic enzyme insufficiency. It almost always presents with recurrent respiratory symptoms. There's going to be cough, there's going to be wheezing, which are absent here. And there's also no documented history of cystic fibrosis or newborn screening results. Now let's move on into the precipitating factors here. And so the options are the following: recent consumption of gluten-containing foods, Clostridium difficile infection, recent viral upper respiratory infection, there's lactose-containing formula, excessive physical activity, and use of over-the-counter antidiarrheal medications. So the answers here are the following. One is recent consumption of gluten-containing foods. Although the gluten products that this child has ingested was introduced recently, it could have triggered an acute immune-mediated enteropathy, especially in a previously sensitized or vulnerable gut, and possibly unmasking an underlying sensitivity or a celiac type of condition. However, the chronic malabsorption from gluten alone cannot yet be confirmed, and so this remains a plausible precipitating factor and not the sole cause. Now, we also have the Clostridium difficile infection as one of the answers here. This is an important contributor to the current diarrhea and may be causing acute mucosal injury, which led to fat malabsorption. And take note that infections like C. diff can mimic, it can also exacerbate malabsorption symptoms, especially in this pediatric patient. And so the other options here, such as recent viral upper respiratory infection, is incorrect, even though this is common in children, but there's no direct evidence that it caused or triggered the current gastrointestinal crisis. So we're going to mark this incorrect. Now, what about lactose-containing formula? Why is this incorrect? It's because this is something that would typically lead to bloating or osmotic diarrhea, but not steatorrhea or hypoalbuminemia. And there's no documentation suggesting recent formula changes as well. So we're also going to remove this one. Now, excessive physical activity is something that you can get rid of immediately. This is something that's irrelevant to the gastrointestinal symptoms or nutrient malabsorption in this patient. And lastly, we have use of over-the-counter antidiarrheal medications. Also incorrect, because there's no mention of their use. Even if it's being used, they would not cause fat malabsorption or hypoalbuminemia. Now let's move on into the potential complications. The first option that we have is severe dehydration. There's electrolyte imbalances, hypoglycemic seizures, pulmonary edema, osteomyelitis, and hyperglycemic coma. So the two answers here are the following. We have severe dehydration, and of course, with frequent watery stools and poor oral intake, and the losses of electrolytes. We have the sodium of 128, potassium of 3, and chloride level of 90. These all indicate a higher risk of volume depletion and hypovolemia. And the vital signs show some tachycardia and borderline hypotension supporting this. So we're going to keep that one. The next is severe or electrolyte imbalances. The child has both the hyponatremia, hypokalemia. These are all related to the gastrointestinal losses, and these are urgent complications, and these must be managed promptly. And so the other options here, such as the hypoglycemic seizures, this is incorrect because there's no report of hypoglycemia. The altered mental status is much more related to the low sodium and also the dehydration. Now, we also have the pulmonary edema. That is incorrect. There are no signs of fluid overload in this case. There's no signs of respiratory distress or abnormal breath sounds to support this problem. Now, osteomyelitis is also incorrect because no musculoskeletal complaints or fever have been reported, and it's not related to the GI or the nutritional symptoms that we are seeing. And lastly, hyperglycemic coma. There's no hyperglycemia or altered consciousness due to this type of diagnosis. So what I want you to do in this test question, I want you to read the entire scenario first, including all the clinical notes and the laboratory findings. So don't just jump into the answer choices until you have read the progress notes, until you have reviewed the vital signs, the symptoms, the lab values, and also until you have understood the timeline. You have to take a look whether the manifestations are recent versus chronic, and also make sure that you note about the risk factors, such as the dietary changes or possible other precipitating factors, such as the infection that this patient is having. Now, the next step that you need to do in this test item is to identify the clinical cues. So you have to ask yourself, what really stands out in the progress notes or the lab values? Is it the pale, dry skin? Is it the frothy, foul-smelling stools? Is it the muscle-wasting, distended abdomen? Or is it the low albumin, the low hemoglobin, or the elevated stool fat? And you have to assess also the scenario if these findings are acute versus chronic, or are these signs of a gastrointestinal infection. And so in this case, the acute malabsorption crisis is a better fit than a chronic process. Now, the next thing that you need to do in this question is to apply the process of elimination, especially for those distractors. You got to eliminate those options that don't fully explain the entire picture. And so, for example, we have the DKA in this column. There's no hyperglycemia. There's no lab value supporting ketosis or acid-base imbalance. And for IBD, there's no blood in the stools. There's no fever or abdominal gargling. With the lactose intolerance, there's no clear link as well. Now, the next step that you're going to need to do here is to link the precipitating factors to the central problem. So you got to ask yourself, what event triggered this acute decompensation? Is it gluten introduction? So it does make sense. Also, the C. diff infection. This is a complicating factor, but it's not the root cause, but it's still considered as a precipitating factor here. And the other options here, which are already discussed, you got to remove those. And the next step that you need to do here is to use your knowledge of pediatric gastrointestinal disorders to prioritize the most likely and most dangerous causes. And then you're going to have to match the correct complications. Once you identify the central problem, ask yourself, what are the likely downstream effects? So here, you're going to think about the fluid status. Is there going to be dehydration? Is there going to be losses in the electrolyte levels, right? Or electrolytes, rather. And also, think about the others, like glucose. Is it involved in the case? Is it significant? Is it affecting the lungs? Of course, we don't have the manifestations that will support to a problem called pulmonary edema. So you got to do that type of elimination pattern. All right, so I hope that you're able to capture all those incorrect answers or distractors.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Let's have our third test type here. This is a matrix multiple response. So just to do a quick review here in the ED nurse's notes. There's nothing new here. And the same thing with the lab values. So let's go right away into the task here. Or there's a new phrase here. It says the ED nurse anticipates healthcare provider orders to address the child's condition. For each potential order listed below, indicate whether it is indicated, contraindicated, or irrelevant by clicking the appropriate column based on the current clinical presentation and lab results. All right, let's get started. So the first potential healthcare provider order in the list is initiate IV fluid bolus with 0.9% saline, 20 mL per kilogram over 20 to 30 minutes. So what do you think about this? Is this indicated, contraindicated, or irrelevant? For this order, this is indicated because the child's severe diarrhea, remember that he had 6 to 7 stools daily, plus 3 more in the past hour and a half. And the child also has low blood pressure, 88/52, even though it's not critical yet. This is a bit lower than the typical 90/55 for this 2-year-old patient. And so this alone shows significant fluid loss, which is a serious threat to the patient's circulation. And so to fix this quickly, a bolus of 0.9% saline at 20 mL per kilogram, which is about 184 mL for this child, this should be given over 20 to 30 minutes. And this is a standard pediatric dose to treat acute dehydration, and it will help restore the fluid volume in the blood vessels right away. Plus, it'll start addressing the low sodium of 128 milliequivalents per liter and chloride that is 90. Also, this can help with the neurologic function to prevent further lethargy and circulation. And so this intervention is very necessary because the child is still losing fluids. And since IV access is already in place, this is a top priority nursing action. So you got to keep this in mind. Now, what about the second intervention or prescription here? We have administer oral rehydration solution, or ORS. So what do you think about this one? All right. So the verdict here, this is contraindicated because our child is lethargic and also showing apathy and refusing juice or crackers, all of which point to impaired neurologic function and poor tolerance for anything by mouth. And that's probably from the dehydration and low sodium of 128 milliequivalents per liter, right? And so the ORS only works if the child can drink and absorb fluids properly, which is not the case here. And trying oral fluids could even lead to choking. This child could potentially aspirate if they're going to end up doing that. And this can also delay the IV treatment, which this client really need. So in this kind of emergency, the IV fluids in number one are definitely the safer and more effective way to support the circulation and to start things around here. Now, let's look into the third potential provider order. It says start metronidazole IV 7.5 milligrams per kilo every 8 hours. The verdict here is indicated because our client is positive for C. diff, which is an active infection that's likely causing the child's worsening diarrhea, now up to 6 or 7 watery stools per day. And so when we're going to administer this is going to work out to about 69 milligrams for this child every 8 hours. And that is a standard treatment in this child for this kind of infection. And so starting this medication right away can help control the infection. It will reduce fluid losses. It will ease the symptoms, all of which will support circulation. Plus, it will help prevent the spread of this highly contagious bug. And so getting this antibiotic going in the emergency room is really important. And this fits right in with the overall infection control plan. Now, moving into our next possible order, which says transfuse 1 unit of packed red blood cells after ABO typing and matching. What do you think about this one? This is considered irrelevant. We know that the hemoglobin level for this child is slightly low at 9.8. Normally, they should be around 11 to 13 grams per deciliter. It indicates mild anemia, but there's no evidence of acute bleeding or respiratory or distress. So airway and breathing are intact here. And for the circulation, this level doesn't impair oxygen delivery enough to warrant immediate transfusion. And this is typically done when the hemoglobin is below 7 to 8 grams per deciliter, or whenever there are signs of hemodynamic instability. And so a 1 unit of packed red blood cells requires time for typing, the matching, and it will also delay focus on the urgent priorities like fluids and also treating the infection. So it's not contraindicated, but irrelevant at this point. Now, moving into our next potential order, we have administered potassium chloride, IV 0.5 milliequivalents per kilo over 1 hour. So what do you think about this one? We know that the potassium level for this child is 3.0, but do you think that this is indicated or contraindicated or irrelevant? So for this is indicated. We know that the child has hypokalemia. It's below the safe range, and this could seriously mess with the child's heart rhythm, which is a big deal for circulation. And so when you are giving this dose, about 0.5 milliequivalents per kilogram, or that's about 4.6 milliequivalents for this 9.2 kilogram child, over an hour after an initial fluid bolus is typically safe, and this is a good way to start correcting this hypokalemia. And of course, we'd have to monitor the child closely using a continuous cardiac monitoring device, and also to do another check on their potassium level, since the child already has a fast heart rate and is still losing fluids. And so we need to fix this hypokalemia urgently. But we need to make sure there's good urine output first to avoid a complication. And so this is the first key to protecting the heart and stabilizing the circulation. So again, make sure that your child here must have the hydration first, and then we're going to have to correct the hypokalemia. Now, the next potential order is provide a high-fat, gluten-containing diet. What do you think about this one? Well, obviously, this is contraindicated, right? Because the symptoms started right after gluten was introduced about 5 days ago. Things like ongoing diarrhea and lots of fat in the stool point to the malabsorption of the nutrients. So this is closely associated to celiac disease. And so when you're going to give this child a high-fat or gluten-containing diet right now, it would just make things worse. And since their gut isn't absorbing properly, especially fats, it will only increase the diarrhea and fluid loss, and it's going to put more strain on their circulation. So right now, our focus is stopping the diarrhea and getting their fluids back up. Now, what's next? We got number 7, which says, place the child in contact isolation. Do you think that this is indicated? Of course. It is indicated because this is an active infection, and this bug can easily be transmitted via contact. And so when you're going to put this child on this contact isolation, this is huge, especially in the ER. This will help protect other patients and other staff from getting sick. And it's a basic but essential step in infection control. Plus, this goes hand in hand with giving the antibiotics like metronidazole to actually treat the infection. Let's move on to our next potential order. It says administer sodium bicarbonate IV, 1 milliequivalent per kilogram over 30 minutes. This is irrelevant because there's nothing here that shows the child has metabolic acidosis. There's no pH or bicarbonate level in the labs to confirm it. And in fact, the low chloride level, which is 90, take a look here, milliequivalents per liter, along with the diarrhea, actually points more toward a possible alkalosis, not acidosis. And giving sodium bicarbonate is something that would only do if we knew the child had acidosis, and that's not the case. And when you're gonna give the bicarbonate, this could make things worse. It might or push already the hypokalemia much even lower. Yeah. So think about that. It can actually cause more potassium to shift from the vascular compartment into the intracellular compartment. And this is going to be, place this toddler at a very dangerous situation if we're going to administer that. So the next one we have is chest x-ray to assess respiratory status. What do you think about this one? Well, this is irrelevant. The respiratory rate at 32 breaths per minute, which is totally normal for this 2-year-old, because their usual range is somewhere between 20 to 40, and there are no signs of breathing difficulty. There's no cyanosis, and that tells us their breathing are okay right now. And so when we're gonna anticipate having a chest x-ray, it would not really help with the bigger problems that are going on here, like the dehydration and the electrolyte imbalances. So what matters right now, again, is getting the fluids in and replacing the electrolytes, and also treating the infection. So chest x-ray is irrelevant this time. And lastly, we have consult gastroenterology for urgent endoscopy. What do you think about this one? All right, the verdict here, it is irrelevant. Even though a gastrointestinal doctor or a gastroenterology consult is being mentioned in the notes, there's really no need to rush into doing an endoscopy in the emergency room. Right now, the main focus has to be on keeping the child stable, make sure that their circulation is supported with the fluids and the electrolyte replacements. And also, yeah, we have the potassium and the sodium. So we definitely need to replace these things to protect brain and heart function, and also to treat the C. diff infection right away. And the high fat content in the stool, the pending test for gluten sensitivity, also suggests there might be malabsorption issue, but that is something that we can look into later. And the endoscopy isn't going to fix the immediate problems right now. So this is something that can wait until the child is out of danger. Okay, so take note of those. So for this type of question, I want you to go into the test taking strategy, applying the ABCs in the case. So don't forget about airway, breathing, and the circulation. Our patient's airway is stable, the breathing is stable, there's no distress. However, the circulation here is compromised. There is low blood pressure because of the ongoing fluid loss from the diarrhea. And when you're going to look into the disability or the neurologic function, this is actually impaired this time. The client is lethargic. There's also poor oral intake. Now, also consider about the infection here. Infection control is really something that you should address here, because C. diff can be easily transmitted. You got to initiate the contact isolation right away as soon as you know the lab results. And once you have evaluated the ABCs and the clinical priorities, your next step is to analyze each order individually. And you got to place it into one of the three categories. Either it's indicated or contraindicated or irrelevant. And so for those indicated orders, you got to ask yourself, is this doctor's order or is this provider order directly gonna treat the ABCs, or will it treat the neurologic status, or will it treat the ongoing infection? And so these are the top priority orders. And also ask yourself if these provider orders can address the immediate physiological threats, or if this can help reverse the underlying cause or deterioration. And so these interventions are safe, timely, and aligned with the clinical needs. So the things that you should consider as indicated are the administration of the IV fluids, because our patient is already manifesting hypotension. We need to restore the circulation stability. We have to administer the antibiotics because of the active infection, and we need to correct the severe electrolyte imbalances. We got hypokalemia, hyponatremia, and hypochloremia. And I want you to go into the contraindicated provider orders. So you got to ask yourself, is this order going to worsen the client's current condition based on their clinical presentation? And so the contraindicated orders here are considered unsafe. They are harmful in the current context. So in paper, they may look acceptable, but given the client's unstable or specific condition, they are not appropriate at this time. And this could lead to complications, delayed recovery, or can further the deterioration. And so one of those orders that are contraindicated are giving the ORS because our patient is lethargic. There's aspiration risk, and also feeding gluten to a child with a suspected celiac disease, or starting medication without monitoring the labs, such as administering potassium chloride, or administering bicarbonate rather, that is IV. All right, so you gotta have to screen or filter all those provider orders. Now, for the irrelevant type of potential orders, you have to ask yourself, is this physician's order have a immediate benefit, or is it going to address the current problems the patient is having, or is this something that can wait until the patient is more stable? And so these type of orders are not harmful, but also not helpful right now. And they may be a useful order at a later time once the patient is much more stable and the other critical findings are under control. And sometimes they address chronic issues or routine diagnostics, but not really relevant to the acute setting. And so the following orders that we have identified as irrelevant are transfusion for the mild anemia, and having a chest x-ray, and getting a gastrointestinal consult while the patient is still in unstable state. So I hope that you're able to capture all these things. Let's move on to our next item, number 4. So this is a drag and drop close test. And the scenario is updated here. It says, the day following admission, the healthcare provider made a preliminary diagnosis of gluten-sensitive enteropathy based on clinical findings. The nurse then reviewed the updated laboratory and diagnostic test results to continue planning appropriate care. So we have the results for the following tests. It says tissue grams glutaminase IgA, it's 102 units per ml, and the anti-endomysial antibodies is positive. So your task is to complete the statement below by selecting the appropriate option from each menu to describe the disease process and priority of gluten-sensitive enteropathy. So here we go. We have our paragraph that you need to complete. It says the primary condition involves an autoimmune response where blank in the diet causes damage to the blank. So let's focus first into these two blanks. So the option for the first blank, we have gluten, lactose, fructose, and sucrose. And the options for blank 2, we have intestinal lining, pancreas, liver, stomach lining. Obviously, the options for blank one's quite obvious, right? So the answer for that is gluten. We know that this is the triggering antigen in celiac disease, which is an autoimmune disorder. And so when someone with celiac disease consumes gluten, which is the protein found in wheat, barley, and rye, the immune system will attack the lining of the small intestine. This is going to cause an inflammation and damage to the villi, which can lead to the malabsorption and a range of systemic issues like anemia, steatorrhea, and protein loss. Of course, the other options here are incorrect, such as the lactose, fructose, and sucrose. Why is that? Because when we are talking about lactose intolerance, this is a non-immune condition caused by lactase enzyme deficiency, which can lead to bloating, gas, and diarrhea after dairy intake. And it may occur secondarily in celiac disease due to the damaged villi, but it is not the immune trigger. The same thing with the fructose. When you were talking about the fructose malabsorption, this can result in gas and bloating, but this is not related to autoimmunity, and it does not cause mucosal inflammation or villus atrophy like gluten does in celiac disease. So we're going to eliminate that one. For sucrose intolerance, I'm talking about, this is something that usually going to happen due to a congenital sucrase isomaltase deficiency, and this is unrelated to celiac disease, and sucrose is not the dietary substance that causes autoimmune small bowel damage, so eliminate that as well. So the answer for the second blank, let's take a look again into the statement here. In the diet causes damage to the blank. So we have intestinal lining, pancreas, liver, and stomach lining. And so the correct answer here is intestinal lining, obviously, right? We know that celiac disease can cause autoimmune destruction of the small intestinal mucosa, specifically the villi and the crypts in the lining. And so this will lead to a loss of absorptive surface area, which can cause steatorrhea, anemia, and nutrient malabsorption. And take note that the damage is localized to the small intestine's lining, and this is reversible with a gluten-free diet. And so the rest of the options, such as pancreas, liver, stomach lining, are incorrect. Of course, pancreas is involved in enzyme secretion, but it is not the direct site of autoimmune injury in celiac disease. And pancreatic insufficiency may contribute to malabsorption in other conditions, but not primarily in this condition. The liver is also incorrect. While mild transaminase elevation can occur in celiac disease, the liver is not the site of mucosal injury. It is affected secondarily, not directly. Lastly, we have stomach lining, also incorrect, because this may be involved in other disorders like gastritis or the Helicobacter pylori infection. But celiac disease does not target the gastric mucosa, and the stomach is not primarily involved in gluten sensitivity. So let's move on to our next statement here. It says, a complicating Clostridium difficile infection exacerbates diarrhea and electrolyte imbalances. To address these conditions, the nurse's priority is to blank and blank to stabilize the patient and promote recovery. So let's pay attention to the options for the blanks 3 and 4. So we have the following options for blank 3: administer high-dose corticosteroids, start prescribed antibiotic therapy, restrict all dietary intake, encourage a high sugar diet. What do you think about this one? The answer for blank 3 is start prescribed antibiotic therapy, because this patient has active C. diff infection as confirmed by the stool culture. And this type of infection can cause profuse watery diarrhea, which will worsen electrolyte imbalance, and it can also increase the risk for complications like colitis, even sepsis. And so the immediate priority is to initiate appropriate antibiotic treatment, usually oral vancomycin or fidaxomicin, to control the infection and also to reduce the fluid losses. And so the rest of the options here are incorrect. We have administer high-dose corticosteroids. It's because steroids are used for autoimmune inflammation, but not for treating C. diff. In fact, steroids can worsen C. diff infection by suppressing the child's immune response, and it's also contraindicated unless treating refractory celiac disease without infection. So think about that. Another incorrect option here is restrict all dietary intake. Well, that equates to fasting, right? It can worsen the malnutrition, and especially in this child that is already experiencing nutrient loss and they already have serum albumin that is already low. And so we need to do much more of nutritional support, which is very critical here. Not going to restrict that. And lastly, we have encourage a high sugar diet. This is contraindicated in this case, especially during a diarrhea, because sugars can cause osmotic diarrhea. It can pull more water into the intestines. It will worsen the child's symptoms, especially during an active C. diff infection. Now, lastly, we have the options for blank 4. Provide nutritional counseling for a lactose-free diet, monitor for signs of respiratory distress, administer intravenous iron therapy, and facilitate referral to a gastroenterologist. What do you think would be correct here? The answer to that is facilitate referral to the gastroenterologist, because we know that celiac disease requires long-term management by a specialist, and they can confirm the diagnosis with intestinal biopsy if needed, and it will manage ongoing nutritional complications, and such as the growth delay or even vitamin deficiencies. And they can also help educate on lifelong gluten-free diet adherence. And so this action will help promote long-term recovery and stabilization. And so the rest of the options here, such as provide nutritional counseling for a lactose-free diet, up to here or administer IV iron therapy, these are all incorrect. We know that lactose intolerance may occur secondary to the villus damage, but it is not the root cause in celiac disease. So providing nutritional counseling for a lactose-free diet is something that you can get rid of right now. Now, the monitoring for signs of respiratory distress is also incorrect because there are no manifestations reflecting respiratory compromise in this case. Administering IV iron therapy is also not indicated here, although the client has mild anemia, but the priority is to treat the underlying causes first. We have the malabsorption and the infection. And so the iron therapy is considered secondary, and this can be started orally after the absorption has already improved. Now, for this type of test, I want you to use the data to diagnosis to priority type of approach. So I want you to analyze the data first, including the lab values and the clinical cues. So look back into the transglutaminase IgA, which is also associated with the positive anti-endomysial antibodies, or the EMA. These two tests are actually specific. They are highly specific for celiac disease. And so the lab values that we have already seen earlier, like low albumin, the anemia, the high fat content in the stools, the low electrolyte counts, such as the potassium, the sodium, indicate malabsorption and nutritional deficiencies. And also don't forget about the C. diff culture that is positive in this client. This indicates a complicating infection. Now, when you're going to see this type of question, especially dealing with fill in the blanks, you've got to make sure that you're connecting you're going to connect them to the pathophysiology of both C. diff and also the problem that we have identified here. So I want you to ask yourself, what dietary agent triggers this immune response? Of course, there's no other than gluten, right? And for the second blank, this is actually asking for you to the organ structure that is damaged. Of course, that is the intestinal lining. And so you have to move on by asking yourself, what must be treated first to stabilize this child's condition? Well, of course, that is the antibiotic therapy to treat the C. diff infection. And lastly, for blank 4, this is going to lead you to ask yourself, who's going to manage the chronic autoimmune gastrointestinal condition? Of course, that is going to be the gastroenterologist. And after you have identified those, I want you to eliminate those distractors using safety and priority rules. So you got to eliminate those non-specific choices that are not related to the condition or not immediate priorities. So what I want you to do here is to treat the life-threatening condition first, which is the infection, the hypovolemia, and you're going to also address the chronic disorder by choosing this option right here, facilitating the referral to a gastroenterology. And that is one of our actions in this case. So you need to avoid those other choices that can delay the treatment or something that could worsen the client's condition by giving them sugar diet or putting them NPO, or yes, putting them NPO without reason. So I hope that you're able to eliminate those distractors in this question.
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Let's move on to our next one. Fifth question we have, it is a matrix multiple choice. So your task here is to indicate the clinical finding, whether it is associated with gluten sensitive enteropathy, or known as the GSE, or cystic fibrosis, or tropical sprue, by clicking on the appropriate column. So I really want you to associate or think about the manifestations here, if they are not associated or associated at all. So let's take a look into the watery diarrhea. What do you think about this one? Watery diarrhea is something that you would see in GSE, or the gluten sensitive enteropathy, because when someone ingests gluten containing food items, it will trigger the immune reaction that will damage the small intestine, and then it's going to mess up how the body absorbs the nutrients, even water and electrolytes. So this can lead to watery diarrhea. So the worsening diarrhea after the gluten exposure fits perfectly with this condition. Now, what about cystic fibrosis? Do you think that this is also associated? Yes. Because in cystic fibrosis, the pancreas does not work properly, so the body cannot break down the fats and other nutrients effectively. This is going to cause diarrhea, which is often watery and sometimes fatty, and again, something that is expected in a client with cystic fibrosis. Now, what about tropical sprue, or TS? Yes, it's also expected, because TS can damage the small intestine, usually from bacterial overgrowth, which can lead to watery diarrhea, since the body cannot absorb water or electrolytes properly. And this continues until it's treated with antibiotics or folate. Now let's move on to our next finding: pale, oily, frothy stools. What do you think about this? Well, this is something that you're going to expect with a GSE. There's going to be there's going to be a problem in the small intestine here. It's going to get damaged, and so fat can't be absorbed properly here. So it will be reflected by pale, oily stools that are hard to flush. And so this is a typical symptom that you're going to see in this client after they eat gluten. Now, what about cystic fibrosis? This is also cystic fibrosis. Hang on a second here. With this manifestation, pale, oily, frothy stools, they also gonna have that. I forgot to put a check mark here. But it can lead to that because the pancreas does not produce enough digestive enzymes in this case, and the fat from the food is not digested well. It will lead to greasy, frothy stools, and again, something that you will see in CF. And the same thing with the tropical sprue. TS can affect the fat absorption, though not as severely as GSE or the cystic fibrosis, but this can also lead to pale, oily stools, which is a common symptom as well. So I'm going to put a check mark here. Forgot to put that. And so the next assessment finding, we have markedly elevated stool fat content. Yes, this is going to be seen in GSE because of the damage in the intestine, small intestine specifically. This is going to make it hard for the body to absorb fat. It's going to increase the fat content in the stool. And again, this is a key diagnostic feature of celiac disease. And again, based on the client's lab value, that is already confirmed. All right. Now, what about cystic fibrosis? This is going to be seen as well because the pancreas does not produce enough enzymes. So fat from the food doesn't get broken down as well. And so this will cause high fat content in the stool, which is a major clue in diagnosing CF. Now let's move on into the tropical sprue. This is also seen in here. Again, tropical sprue can also damage the small intestine. That affects fat absorption. It can lead to increased fat in the stool. While it's not as severe compared to the GSE and CF, it's still a feature in this condition. Let's move on to our next one. It says weight below fifth percentile. So, do you think that this is going to be associated with this one? Yes, that is true. Because there's going to be chronic malabsorption in GSE. This will lead to lack of absorption of the nutrients, which results in growth issues and low weight. And again, a very common manifestation in untreated celiac disease. For cystic fibrosis, this can also lead to this problem because the CF itself can cause problems with the digestion of fats, the proteins, and carbs. And so there's going to be poor weight gain. There's going to be decreased growth despite eating enough calories. So this is also a hallmark sign of children with cystic fibrosis. And the same thing with the tropical sprue, something that you should also expect here, because there's also malabsorption. There's going to be weight loss, growth failure, and very noticeable in children in areas, especially in the tropics, where the tropical sprue is common. Now let's take a look into the next item here, distended abdomen. Do you think that this is going to be present in GSE? Yes, because when someone has GSE, it will lead to the malabsorption, gas buildup. It's going to cause the belly to swell. And again, often seen in children with celiac disease who may have a bloated stomach but a thin body. And the same thing with cystic fibrosis. They also have trouble absorbing those nutrients, which can lead to bloating and often gonna cause buildup of gas and undigested food. So this is something that you should expect here as well. And the same thing with tropical sprue. They will have inflammation, malabsorption in the gut, which leads to fluid and gas buildup. So this is going to lead to distension of the abdomen as well. Now, moving into the next manifestation, recurrent respiratory infections. So what do you think about GSE? Is this something that you can associate with it? Well, no. I'm going to put a check mark here, because the GSE mainly affects the gut, not the lungs. So it's not associated with recurrent respiratory infections. And the patient that we have in our case has normal respiratory rate to support this. Now, what about cystic fibrosis? Do you think that this is seen in this condition? Yes. Because one of the main issues in cystic fibrosis is thick mucus in the lungs, and this can cause frequent respiratory infections like pneumonia, bronchitis. Even though the scenario doesn't show symptoms of respiratory infection, cystic fibrosis is still likely. All right. Now, moving on to the tropical sprue. Do you think that this is associated? Not in this manifestation, right? Because with tropical sprue, it does not affect the lungs, so respiratory infections aren't part of the picture. And tropical sprue is much more associated with gastrointestinal symptoms. Let's move on to our next manifestation. We have low serum albumin. So for GSE, yes, you're going to expect this. There's going to be hypoalbuminemia because the proteins are not absorbed properly. This can lead to low serum albumin, and a very common manifestation in untreated celiac disease, and can result in symptoms like edema. In cystic fibrosis, yes, you can also expect this one because the body is not able to absorb enough protein due to the pancreatic insufficiency, which can lead to low albumin levels. And the same thing is true to tropical sprue because there's also protein malabsorption. This can lead to low serum albumin. Moving on to electrolyte imbalances. Yes, you can see this in GSE because of the watery diarrhea. This is going to lead to fluid loss, electrolyte loss like potassium and sodium and chloride, which can cause problems with heart and nerve function. And the same thing is true to CF because of the malabsorption that can happen, and particularly the electrolyte imbalances can occur through the diarrhea and the sweat. And again, there's going to be electrolyte imbalances here as well. With tropical sprue, this is also true here. There is malabsorption and diarrhea, so expect that to happen here as well. And lastly, we have improvement with a gluten-free diet. What do you think about GSE? Of course, it's true here because this is the hallmark of GSE or celiac disease. This is all about gluten sensitivity. And when you're going to remove gluten in the diet, this is going to help them heal their intestine and fix their symptoms, such as diarrhea. And for cystic fibrosis and tropical sprue, these are unrelated, all right? Because these two are not associated with gluten malabsorption. So your test taking strategy here is to recognize the pathophysiology involved with each disorder. So you're not just memorizing facts, you have to recognize the common patterns in how these three disorders behave and how they're going to affect the body and what symptoms or lab findings they're going to produce. So you're given so many multiple options here, and such as the manifestations. So you got to match each one to the correct conditions. And you have to step-by-step break down the options here. You got to focus on one clinical finding at a time. So instead of scanning the entire matrix and getting overwhelmed with so many options, you have to look at each finding separately. And so when you do this, you got to ask yourself here if the evidences or the manifestations are actually associated with that finding. And so you have to also screen if this system is going to be involved here. Is this about the digestion? Is it about absorption? Or is it nutrition? Or is it about the lungs? So this is going to help you stay organized to avoid confusion. And you have to recall the pathophysiology behind each disorder. So you got to think about the causes and the symptoms in each condition. So for the GSE, you're going to identify that there is damage to the small intestine, which is going to cause the malabsorption of the fats, the proteins, and the vitamins. And so the common symptoms that you're supposed to associate here are diarrhea, there's going to be weight loss, there's steatorrhea or a fatty stool, and some nutritional deficiencies. And for the cystic fibrosis, this is a genetic disorder that can cause thick mucus buildup in the lungs and the pancreas. And so the pancreas gets blocked, and so the digestive enzymes cannot reach the intestine, such as causing fat protein malabsorption. And so the common symptoms are going to be steatorrhea, poor weight gain, frequent respiratory infections, and there's also salty tasting skin. So I hope this is helping you in eliminating those distractors. Now let's move on to our last test item. We have a multiple response select and type of question. So the progress notes is updated. We have here day 7 at 9 a.m. The nurse charted condition markedly improved, no stool in 18 hours, abdomen flat, soft, eating well, weight 10.5 kilograms. Discharge is planned for tomorrow. Vital signs temperature 98.6. It's not 0.06 degrees Fahrenheit. Pulse rate of 98 and respirations 24. Blood pressure of 96/60. And we have updated results for the lab values hemoglobin 10.2, serum albumin of 3 grams per deciliter, potassium of 3.8, sodium of 136, chloride of 98 milliequivalents per liter. So your task in this question is to select the statements that indicate the parents did not understand the teaching points by placing a check mark next to each incorrect statement. So let's check each sentences here. So the first one says, we'll keep giving him rice cereal since it's gluten-free. What do you think about this statement? Well, this reflects, or this does not reflect, misunderstanding, and so we're not going to check the box here. We know that the rice cereal is a safe option because it does not contain gluten. And so if they did, or the nurse would have explained that kids with celiac disease need to completely avoid gluten for life, and rice is a perfect gluten-free choice. So this statement reflects understanding rather. So this one, he can have wheat bread again once his stools are normal. What do you think about the statement? This is something that you can check. It's because the parents here missed a key point. Just because his symptoms are gone, it doesn't mean gluten is okay again. And we know that wheat has gluten, and even one slice can cause damage again. So remember, celiac disease is not temporary. It's for life. So gluten has to stay out of this patient's diet forever. Next statement, it says, we need to wash our hands well to prevent C. diff spread. What do you think about this statement? Yes, this is a correct statement. It does not reflect misunderstanding, so we're not going to check the box. And remember that C. diff is super contagious, and regular hand washing is something that would really protect the family members here. So take note that the family or the parents saying that they're going to wash your hands to prevent the C. diff spread, that's an indicator that they have understood the transmission of, or the mode of transmission for this type of infection. And so the nurse, if they've stated that they're not going to wash their hands, well, that's a red flag for this statement, right? So we're not going to mark that one. What about the next question or statement here? It says, we can stop the metronidazole now since it's all better. All right, the answer to that one is yes. That reflects misunderstanding. They're not supposed to discontinue giving the medication. Even though the child is feeling better, he still needs to finish the full 10-day course of antibiotics. And if they're going to stop the metronidazole early, there's a high chance the infection could come back. And the nurse definitely would have warned them to finish all the medication, even if the symptoms go away. The next statement here says we should avoid giving him barley in his snacks. What do you think about this one? This is a correct statement. So simply it reflects that they understood that barley has gluten, and this can actually trigger another episodes of diarrhea if they are not able to tell that this food item contains gluten here. So we're not marking that box there. The next statement says it's fine to give him milkshakes with malt flavoring. What do you think about this one? This is reflecting misunderstanding. It's because malt is made from barley, so that's a no-go. And even though a small amount is harmless, I mean, might seem harmless to them, but it actually contains gluten. And so the nurse would step in to teach them to read food labels correctly and watch out for those sneaky sources of gluten like this one. And we have our next item. It says, we'll watch for diarrhea and call it if it comes back. What do you think about this one? Well, this is a statement that reflects understanding, so we're not going to mark that box. This is spot on. The nurse would have told him to watch for any signs of diarrhea because it could mean that gluten exposure could have repeated, or maybe there's a return of an infection. And if it happens again, they need to get medical help right away. And so this shows good follow through. The next one, it says, his celiac disease means no more pizza unless it's gluten-free. What do you think about this statement? Well, this reflects understanding because regular pizza crust is made with wheat, but there are gluten-free pizza options that are safe for him. And so this shows that the parents learned that all gluten, not just wheat, has to be avoided for life. And so that wraps up our Q&A today. So if you find this review helpful, click the subscribe and like buttons and share it with your friends who are preparing for the NCLEX, and keep up the momentum. Believe in yourselves and go crush that exam. And I wish you all the success as you take this final step. I'll see you again in the next session. Thank you for watching.